How you doing? My name is Ken Cornell. I'm an orthotist for many years now, working up in Boston, Massachusetts. I work at the CMTA Center of Excellence up there in Boston. I'm actually on the CMTA advisory board. I've had years and years of doing orthotics and prosthetics, and my focus has always been on Charcot-Marie-Tooth disease. And so had a great presentation last year. I enjoyed doing it. This whole virtual setting seems great. So the title I have this year is Do I Need AFOs? I know you saw that title in the agenda, but I didn't like the title for a couple of reasons. I think a lot of you have AFOs already. So I wanted to add, do I have the right AFOs for me? And ultimately, no matter what you have for AFOs, the only thing that matters is, do you prefer wearing these AFOs or not? I'm going to try to move this thing out of the way. Hold on. All right, do I prefer walking with them? And a quick story, assuming that you do need AFOs, I get this question a lot. When should I wear them? And I get that question a lot. And the answer, the key word in the answer is the word prefer. So here's a quick story. 25 years ago, my daughter came home from the 4th grade with a note from her teacher that said, your daughter needs glasses. I said, I wouldn't know if my daughter needs glasses or not. Olivia, what does the TV say? She said, Dad, I can't read it. So fast forward, there we are getting her glasses. And she's at the optometrist. She could fit with the glasses. She looks out the window and she says, oh, look, leaves. And I tell you, at that moment, I felt like she was a terrible parent. So then I asked the optometrist, I said, so when do you think she'll need to wear these glasses? And she looked at me like I was kind of crazy. And she said, I think you're going to find that your daughter will prefer to wear them most of the time. And again, that was 25 years ago. And I internalized that right then and there to what I do every day, designing and fitting braces for everyone, AFOs for people. And that's exactly right. You wear them when you prefer to. So when should I wear my AFOs? When you prefer to. If the AFOs you're wearing don't provide you with a wow benefit, then you'll prefer not to wear them, or only prefer to wear them for certain tasks. And that's what I see a lot. You see people get very expensive AFOs, all different kinds of AFOs, and they may come carrying them in, or they may come to the clinic and not even bring them because they just didn't prefer to wear them. They didn't offer any wow benefit. So the short answer to the question is, do I need AFOs? Or do I have the right AFOs? Is you really have to sort of test drive them to really know if you prefer them or not. Now, the long answer to that question begins now. So conceptually, if you answer yes to any of the following 6 issues, you would benefit from AFOs. This is conceptually. If you have falls or frequent near falls, if you have weakness in your feet and ankles, if you have balance problems, if you have fatigue, chronic ankle sprains, usually lateral ankle sprains, or just plain a lack of confidence in walking, then you need AFOs. So let's look at them real quickly here. Falls or frequent near falls. This little guy, there was a time when we all used to fall a lot, and it really wasn't an issue. But if you have any falls with injury, you definitely would benefit from AFOs. If you have falls without injury, or if you have near falls that occur frequently, then you need AFOs. Weakness. If you can't walk on your heels or you can't walk on your toes, you need AFOs. If you have balance problems, and we're going to spend some time talking about balance. If you need to crouch, like Mark is doing here, to steady yourself. If you routinely seek to maintain contact with a stationary object to keep from wobbling, if you're standing in open space and you just can't focus on the conversation you're having because you're occupied with not losing your balance, then you'd benefit from AFOs. Fatigue. If you just can't keep up, if you feel like you just, I say, you just shouldn't be this tired just walking the dog around the block. This is individual for everyone. But when you have this abnormal amount of fatigue. If you don't have a normal gait pattern and you really can't walk on your toes, we're going to talk about this, If you can't get up on your toes, then you basically have lost 70% of your propulsion. And AFOs can restore that. So you would need AFOs. If you have a lack of confidence, if your gaze is downward on the ground or in front of you while you're walking, and if you walk with a stiff or guarded pelvis, some people say, I had one patient who said he liked to look down and count ants every day. And some people are afraid to, roll their ankle if they step on a dime. Then an AFO will help you there as well. They have a history of ankle sprains. Now, this is a picture of a common deformity. Any of you who saw Dr. Pfeffer's talk, you know that he would love to do surgery on someone like this. And, we're limited on what we can do with bracing when it comes to how severe your deformities are. But we have been remarkably successful with managing this amount of flexible deformity here. But if the weight line falls laterally, you're also going to have some heavy calluses. And so if you have this lateral ankle instability and you've got this amount of varus deformity with resultant heavy painful callusing, you need AFOs. So the next question is, what kind of AFOs do I need? And there are many, many to choose from. And what's the best one or particularly the best one for us? So we're going to talk about that. What kind of AFO do I need to restore normal gait? And normal gait, my wife mentioned this when I was practicing too. She says, what is normal gait? Is it the kind of gait I had before this all happened? Is it the gait that my unaffected friends and family have? Normal gait is basically that. It's the kind of gait you had before you had CMT. And we know CMT is progressive in nature, and that the weakness begins distally in your toes and then progresses up the legs in an often predictable sequence. And this depends on where you are with your particular motor or sensory loss as to what type of brace is best for you. And normal gait. This nurse I work with at a PD hospital on Tuesdays, she just had this remarkable gait, so much so that I actually, we put a gait, my belt monitor on her, we got all her gait data, and she just skied every category. She walks beautifully, she walks quickly, arm swing, perfect posture, great pelvic motion, a normal heel-toe gait pattern. And what I mean by a normal heel-toe gait pattern is when the foot hits the ground, you should have this controlled plantar flexion of the foot. You land on the heel, and then the toes get controlled and lowered down gently to the floor. We call that first rocker. Once the foot is fixed on the floor, and the leg and the whole body up above now transfer over the foot, this is what we call second rocker, this motion occurring while the foot is fixed on the floor. Until we get to a certain point where just prior to heel strike of the leading foot, you get heel rise of the stance phase or trailing foot. This seemingly subtle little insignificant detail accounts for 70% of our propulsion. And so for those of you who can't walk on your toes, you're getting 70% worse gas mileage than you did. So what kind of AFOs do I need? Well, if you can't walk on your heels, but you can walk on your toes, you really don't have any significant balance problems, you have no ankle instability, no real fatigue issues yet, and no confidence issues, then for you, you have lots of options. Basically, you're looking for an AFO that just manages just that foot drop or foot slap that you have. That audible foot slap where people can hear you coming down the hall. And really, any AFO is designed to address foot drop, and you can do it. Of course, you'd like to have one that is as least bulky and complicated as possible. And that's what some of these pictures are of. This is a simple dynamic carbon AFO with a little posterior cuff, and it's designed basically just to pick up your foot and allow this normal motion of your ankle here, where in this little traditional PLS AFO, it allows for all that motion through the ankle. It's normal. This brace up here, this new exoskeletal design, it's called an X-Turn. It's really nice. It fits on any shoe, from a hiking boot to a dress shoe to a sneaker, and it provides really extraordinary dorsal assist or toe pickup. It was designed for a guy who just liked to, run up mountains, and jump up on boulders and stuff. And this brace is great for that, and it's virtually indestructible. So if you just have simple foot drop, you've got lots of options. Oops, wrong way to go. So what kind of oh, do I need if I have progressed? And basically by this point, you really can't walk on your toes now. You can't walk on your toes, then by now, knowing about how CMT progresses, you probably can't walk on your heels or tap your toes. You've got some significant fatigue because, again, that ability to get up on your toes or achieve heel rise in that third rocker provides for 70% of your propulsion. So with 70% worse gas mileage, you're going to get tired just walking the dog around the block. You're also going to have some sensory deficits, and you're going to have some balance problems we're going to talk about in a minute. Your gaze is usually people like to keep their gaze down on the ground or in front of them because by the time they have that much weakness and sensory loss, they're uncertain. Every step is uncertain. You go to take a step and you don't know what's going to happen. You're going to twist your ankle, you're going to catch your toe, and your confidence sort of goes downhill. You'll also probably have some moderate ankle instability by this point. So let's talk about restoring balance. Balance is really about managing the weight line throughout the gait cycle and maintaining your center of gravity over your base of support. This person can balance because he has his center of gravity managed nicely over his base of support. So these are the requirements. Muscle-wise, motor-wise, we need good foot and ankle muscle strength to stabilize our joints and provide riding reactions. Riding reactions means that if you're standing up and you start to lean forward, you would push on your toes, and that would right your center of gravity back over your base, and you would maintain your balance. Similarly, if you started falling backwards, you would pick your toes up a little bit, and that would bring your center of gravity forward, and that's these riding reactions that we make constantly while we're trying to maintain our balance. So from a motor standpoint, a muscle standpoint, we need that strength to maintain our balance. We also, from sensory-wise, there are three things we have to think about. You need vision. Vision is great because you can focus on a stationary object and know where you're moving relative to it. Vestibular function is that inner ear stuff, where anyone who's played pin the tail on the donkey knows that if you spin somebody around and then send them across the room, they're going to be dizzy. And that's vestibular function, vertigo, and those types of things. The last one in red here is proprioception. And it's a big fancy word. And what does proprioception mean? Proprioception is the ability to know where a body part is in space and how it's moving relative to the rest of the body. And this happens because it looks like a complicated slide. It really isn't. But inside all of our muscles, all the muscles of our body, we have these things called muscle spindle fibers. These are sensory organs in a muscle. And they send information via these sensory neurons that go, they report the exact length of a muscle at any given moment in time. And when the time it gets up to the brain and our sensory cortex, basically the brain puts all this information together like an enormous computerized puzzle, telling us the exact position of any body part and how it's moving relative to the rest of the body. Now, because it involves these sensory nerves coming from all the way from the muscles down in our feet, all the way up through our spinal cord and brain. Unfortunately, patients with CMT, for them, the communication lines get cut and the longest nerves first, and we lose the ability to know where that body part is down in our feet and ankles. Depends on how far up the sensory deficits have progressed, but that's basically how it works. So CMT patients, consequently, are balance challenged with both muscle weakness and this proprioceptive loss. So how do CMT patients compensate? Well, many compensate by just sort of maintaining contact with a stationary object. Like, for example, a finger on a wall. Put a finger on the wall, you know where you are in space. You casually lean against the wall and you think you're being casual, nobody's noticing, but you know, how many of you out there in the room, I know, will walk across the room and then find something, a wall or a stationary just to make contact with so that you can maintain your balance. You can also do it with a knee against a coffee table. And this is an important concept. So my wife here, who, let me take this photo of her, you know, with a knee against a coffee table. Now, because the information in our feet and ankles can't get up to our spinal cord and brain, we shortcut the whole program. Basically, by putting our knee against a coffee table, now we're getting sensory information here telling us where we are in space. It's a way to cheat this whole proprioceptive loss system. So how does an AFO help us with balance? Well, because these AFOs, especially these new carbon ones, they're dynamic carbon, and I like them a lot for CMT patients, because they're flexible and yet they have resistance to motion. That this brace being in front of the leg is a lot like having a coffee table in front of your leg. You can stand and lean into it, and this is telling you where you are in space. But you're feeling the resistance up here on your top of your leg, and it basically bypasses the foot and ankle proprioceptive piece that's missing and helps you know where you are. There's another thing that goes on here with this brace being in the front of the leg and this brace resisting a lot of not being too flexible down here. This also, if it's strong enough, it should be able to pick your heel up for you as you walk. And remember what a wonderful thing that is. If you can achieve heel rise or get up on your toe prior to heel strike of the leading foot, oh my gosh, that's 70% better propulsion. 70%, and that's fabulous. That helps you with fatigue, and of course, you can then increase your walking speed. And also by knowing where you are as you're walking over your foot, it helps with your confidence a lot. More flexible carbon AFOs back here, many braces are just more flexible. You won't get that ground reaction. They're not rigid enough. It's like you're looking for that coffee table on the front of your leg, but it's really a pillow, and so you don't really feel much there instead. So, sorry, oops, I'll go back. Is there any evidence that this works? Well, this is my chance to plug our recent study on balance. This is now published just in August of this year, Physical Medicine and Rehabilitation International, and this is all done at the CMTA Center of Excellence at Mass General Hospital, Boston. The study was called a pilot study to assess the immediate effect of dynamic carbon ground reaction AFOs on balance in individuals with Charcot-Marie-Tooth disease in a clinical setting. Basically, these are patients who we're seeing for the first time, and we're going to trial a dynamic carbon ground reaction AFO and see if it improves their balance. And the thing about it is, doing this is sort of takes some skill. People who have been doing it for several weeks are much better at it than people who are doing it for the first time ever. And these are the people that we work with at the clinic. Katie Burke, who was instrumental in this, myself, Ken Cornell, and Amy Schwartz, another great physical therapist there. Amy Grant's our clinic researcher. Dr. Sabrina Paganoni, just fabulous, and our leader, our fearless leader, Dr. Reza Syed Sajadi. The results of this study were quite remarkable. Patients got remarkable improvement in their balance from using these dynamic carbon ground reaction AFOs. So that's why I consider myself a dynamic carbon ground reaction AFO enthusiast, because expectations are wow. You do get a wow improvement. And remember, in my experience, if patients don't get just a wow improvement from wearing an AFO, they'll prefer not to wear it or just wear it for certain things. But these dynamic carbon AFOs, they certainly provide ankle stability. They are the only design I know that facilitate all three stance phase rockers, from controlled plantar flexion, ankle motion over the foot, just the right amount, and then heel rise prior to heel strike for that really big benefit of 70% increase in propulsion or a decrease in fatigue. They also, of course, offer that ground reaction, which is helpful for static balance. Now, the strongest of these designs, I've sort of got a few of them here. The blue rocker, which I use a lot of, it's covered by insurance. It just worked really well. And it's also, as far as bulk goes, there's not a lot of bulk to it. There's not a lot of plastic on your leg. This is all fabric in front of your leg here. And it has to be set up with a custom foot orthotic, which is very nice to stand on. And so it works pretty well. We can also do a lot of varus valgus corrections. So if your ankle's rolling to the outside or the inside, we can make some corrections there and accommodate for any callousing that you have. They work well. This design here, there are several different posterior element designs, these dynamic posterior element designs. They're a little bulkier, but again, they provide great ground reaction and restoration of all three stance phase rockers. And they do it, they're a little heavier, but they're just about indestructible too. They work really well. And then of course, the more expensive options, the custom Helios and DR3s do it as well. And I'm missing some, but it's the principle that I'm trying to show, not talk about every AFO that is out there. Gait training. Gait training to optimize outcomes. I'm also going to talk a little bit about gait training here. These AFOs always work better when you know basically what to expect from them, and then you can experience walking with them. There are certain things you can do to help you be a better CMT walker. The first is stand tall, like a soldier at parade rest. And these first two I say are military analogies. Basically, there was a very famous Roman general who I invented for purposes of this discussion, who I say told us how to stand. And when they stood at parade rest. And when they walk swinging their arms 12 inches in front and 12 inches behind. And those are two really important things we're going to talk about in a minute. Also, pelvic motion. You got to shift your pelvis over the leading foot when you walk, and look up. Don't look down at the ground anymore. Look where you're going. Oops, sorry. So I chose a military person standing in parade rest just to illustrate this. But if you can stand like this in your AFO, have a ground reaction AFO that will simulate the effect of a coffee table, so you know where you are in space and you've got good static balance. It takes very little muscle activity to stand this way just because the weight line is managed so well. Conversely, if you stand like a gorilla, all these muscles are all turned on right now trying to stabilize your body, your center of gravity, and keep you erect. And even a gorilla, for all his strength, much stronger than a man, he can only stand this way for a few minutes, and then he has to move around or use his hands or change his weight bearing. Contralateral arm swing. There's a reason why we swing our arms when we run. And there's a reason why this Roman general was invented. And they still do it today. Teach their shoulders to march with their arms swinging. Contralateral arm swing, 12 inches in front, 12 inches behind. When you walk that way, your muscles lengthen the optimal amount so that they have the most power to then shorten to give you the most power that you can walk with. And that's why contralateral arm swing is so helpful. So when you're walking. So if you're standing at parade rest and you're walking like a soldier, like a cadet on graduation day, you'll have much more power walking. You'll optimize the power that you have. Oops. All right. Pelvic motion. Pelvic motion is key even to athleticism. The best athletes can move their pelvis better than their competitors. And pelvic motion is kind of intrinsically attractive to us. I always say, and I say it, my secretary laughs every time she hears me say it, but there's a reason why men like to watch women walk away. And that's because when they're moving the pelvis like that, it's instinctively attractive to us. It's showing us that there's a good, healthy, person there. It's attractive to us. And even for the men don't like to move their pelvis when they walk. They don't want to wiggle in the walk. They want to walk like a tank. But when John Travolta walks down the street and a paint can swinging in his hand and he's, moving like he does, it's very attractive. And it's because it's just showing us that's a good, strong, healthy person there. I keep hitting the wrong button here. And I've got some video comparisons here. This is a guy named Chuck. Now, I apologize for the audio. I'm not a professional videographer, and you'll hear some background noise and stuff. But we're going to show you how this guy Chuck, how he walks without his AFOs. He's had them for years, but here he is walking Walk back and forth now. And how steady are you now?
I don't feel steady at all. You know, my steps very much tripping, and then I keep feeling myself wobbling.
Okay.
I can't move as fast either.
Okay. All right, stop short right there. And you got to keep your knees crouched a little bit. And can you look up at the sky? And look around the room. How's your balance? Yeah. Okay. Lose your balance. All right, good. All right. Thanks, Chuck. So when Chuck is walking here, I'm asking him to stand balanced. Typically what we'll do is we'll ask patients to stand with their hands on their hips and what we call a Romberg test. Chuck would fail a Romberg test, and we do it 3 ways. We do it in double limb support with both feet on the ground. We'll test them in single limb support with 1 foot in the air, and in what we call tandem, when they're standing like they're on a tightrope, 1 foot in front of the other. And it all should be with your hands on your hips. And Chuck fails all 3, basically. The first thing patients do when they're looking for balance is they will generally crouch. And when patients crouch down, what it's doing is it's putting more strain on a lot more muscles, so they're getting a lot more sensory information telling them where they are in space. And that was Chuck walking there with no AFO. So here he is walking with them. He starts a little reckless, but here he goes. Okay. Yeah. And good walking, just back and forth. You make it look effortless. That's awesome. Okay, and come back, and this time just stop short right there. Just stand like you would, like you're gonna talk to somebody. How's your balance? Good. Yeah. Put your hands on your hips, no problem. Okay. Yeah. Point around the room, look up at the ceiling. That's awesome. Good balance. That's awesome. And he did much better with the AFOs. Myself professionally watching him, right away I noticed he has restoration of all 3 stance phase rockers. He's not only getting a nice heel strike, but he's getting good heel rise when he walks. His pelvis is moving too. You notice he didn't walk very stiff, rigid, and guarded. Now, he's had several years of experience walking with them, and I find this is true too. And last year I did a little talk on these 2 guys. One was Chuck, and one was a guy that was just about his size, age. They were very, very similar, same type of CMT. Without AFOs, they both had very similar deficits. They walked the same way. When Chuck was getting new AFOs replacements, and the other guy was getting them for the first time, I videotaped them both side by side. And it was amazing how much better this guy here, he could walk better just from having better habits for several years than the other guy did. Now, when they put the AFOs on both of them, they both walked beautifully. But a lot of people are worried too that if they wear an AFO, they'll get weaker. And there's been a couple of studies now that show that actually the opposite happens. If you wear a dynamic carbon AFO that forces you that helps you to walk in a more biomechanical way, calf circumference increased on those patients when they had them and decreased when they went back to different style of AFOs that may have immobilized the foot and ankle. And so Chuck had the advantage of, I think, being a little stronger, even proximally up around his hips after wearing them for so much time, and just walking better and having better habits than the other guy did. And the last video I have, and I'm doing really well on time here actually, holy smoke, is a video of Chuck, and he's going to give you just some candid remarks. And again, I apologize because you hear my admin in the back talking and stuff, but I think it's important. This is my own patient's opinion. So let's stick with that here. Going back and forth now. Here we go. In a nutshell, like how they help you the most.
Yeah. With the braces, I noticed the first day that I got to work, I was standing there having a conversation with one of the guys I work with. And for the first time, I listened to the whole conversation. I never had to worry about where I was, what I could lean up against.
Yeah.
I was able to pay attention to what was going on without having any worries about falling, balance, or anything, and it made a huge difference. I also noticed it boosted my confidence level 100%. I wouldn't go to the mall. If I was in a room at a meeting with a bunch of people, if I needed a cup of coffee or I had to go to the bathroom, I would wait until it was all over. I wouldn't get up and walk in front of anybody.
Yeah.
So it completely changed my attention, my ability to listen to what was going on with other people, my confidence to go places that I've never gone before. And so it was a total life-changing, attitude-changing experience for me, and it's allowed me to do a lot of things that I couldn't do before. So
you mentioned sneaking up on people.
Yes, before at work. I work at home too. I come around the corner and the guys would say, "Oh man, we don't like this. We used to be able to hear you coming." I would start working past them. We knew the boss was coming. Well, my daughter, I'd be in the hallway and all of a sudden I'd be behind her and she'd be like, "Where'd you come from?" So they didn't like the fact that I was now stealthed and quiet and wasn't clomping around. But it was nothing short than a complete attitude and life-changing experience.
Wow.
Totally.
Yeah, that's great.
Not having to think about balance and standing that consumed my every minute of the day. Yeah.
Thanks a lot, Chuck. Appreciate it. Thanks, man.
Hope that was good enough.
Yeah.
And now I can take questions. Hello? Is anybody there? Hope I didn't just talk to nobody.
Hi, Ken. Thank you so much.
Hi.
So we can go ahead and get into our Q&A session. So I'm just going to add a couple questions to the stage.
Okay.
And let's see. Here's our first one. My daughter, who's 3, has just been diagnosed with CMT1B. She falls 4 to 5 times a day. Would she benefit from AFOs? Since she's young, is it better to brace her now or wait? Would it weaken the muscles if we braced early?
Great question. So if your daughter's, she's just 3 years old, that's very young to have that kind of weakness, but that's typically what we hear, mothers will tell us that, typically their child is a little more clumsy and they trip or fall. Does she need AFOs now? I say yes. There are some nice, simple little braces we can do. Sometimes just little SMOs, tiny little braces inside of your shoes. They can help somebody just to keep their feet straight. This raises a lot of questions for me too. But I mean, is there any deformity showing up yet? We can oftentimes brace patients young like this who look like they're progressing quickly to apply forces, on the foot to limit or mitigate the deforming forces there and keep the foot straighter as she's growing. As far as preventing tripping and falling, yeah, absolutely. There are very simple little braces we can make. They can just make the foot in the right position all the time. And again, as far as her getting addicted to them or just making her weaker, we find that if we do it the right way with these carbon AFOs, that the opposite is true. Patients will actually stay stronger and walk better as they progress with the brace. So yeah, I would say now's the time.
Fantastic. All right, so let's go to the next one. What are your thoughts on Neuro Swing AFOs or KAFO AFOs for a patient who severely progressed with significant weakness and frequent knee collapses?
Great question. We don't see a lot of CMT patients that have a lot of collapsing knees. Sometimes it can be done with just a ground reaction AFO, and the Neuro Swing can certainly do that. The Neuro Swing is something that I've been very interested in, and I've got an associate of mine, actually another man on the other guy on the CMTA advisory board, Dave Meisner, actually has a lot of more experience with it than I do. The trouble with the Neuro Swing is I'm having a hard time getting it covered. And I know it had some breakage problems in the beginning, but it has potentially the benefit of being able to adjust how much force we're going to resist with plantar flexion versus dorsal flexion of the foot, which can be very helpful. But again, unfortunately, I don't have a lot of experience with the Neuro Swing itself. just because we haven't been able to get it covered by insurance. But I love the concept of it. And again, my friend David Miser, who's also on the board, could probably be another good resource for you to call and ask his opinion on it. As far as knee weakness goes, there are some other ways to go about it. As far as knee weakness goes, using a bigger brace, a brace that goes above the knee, what we call a KAFO, they would have some sort of stance control lock or a knee lock. Well, that's harder to do, and people don't like wearing bigger, bulkier braces. If ground reaction isn't enough for these patients, then what we do is I'd recommend doing a very simple KAFO, one that actually lets the knee hyperextend a few degrees. And if you can let the knee hyperextend a few degrees, basically it becomes inherently stable. And that can be made in a very lightweight way and still control the knee from progressing into too much knee hyperextension and what we call it a genu recurvatum deformity, where the knee hyperextends too far the wrong way. We can still control that, but let it hyperextend just enough that when you stand on it and you're loading the knee, it has inherent stability. Again, a lot of questions with that question, because what's going on at the foot and ankle? Is there a lot of deformity there? Is there a flaccidity weakness there as well? Is there any fixed deformity? All those things that have to be taken into consideration. But again, the Neuro Swing, I really like the concept of it. I just don't have any personal experience with it. As far as knee weakness goes, yeah, I have 2 patients that are in KAFOs for CMT. That's only 2 out of my huge population. So again, it's not a big percentage of patients that need knee control for knee buckling, where the knee is so weak and the disease has progressed to the point where we're actually just buckling at the knee. But that strategy I mentioned with using the KAFO to let the knee hyperextend has worked well for them. I hope that's helpful and answers your question there.
Fantastic. All right, so let's go ahead with the next one. Are silicone AFOs good for someone that walks on their toes, needing ankle stability, ball, foot support, no foot drop, hammer toes, horrible bunions?
Again, I showed an image of it in one of the earlier slides. The silicone AFO is made by a company in Dorset in England, and I think Hanger OMP has a proprietary relationship with them. So again, I don't have a lot of experience with them. It is good. Patients report that they like it for just simple foot drop. For someone that walks on their toes, if that means also that you've got an equinus deformity, where your Achilles tendon has gotten short and tight and making you walk on the heel, then you would have to have some sort of, compensatory heel lift. You have to walk in basically high heels to accommodate that part of it. The silicone AFO offers mild stabilization. It's not going to stop the ankle from rolling laterally. It's certainly not going to provide you if you can't walk on your toes. If the muscles in the back of your leg were so weak that you couldn't walk on your toes, it's not going to help you there either. This is basically for someone who has just mild symptoms and they want just a little bit of assistance with foot drop, and it can help with some proprioceptive loss as well. I noticed in the notes it says you have no foot drop, you have no hammer toes or horrible bunions. Again, if it's just for simple joint flexion weakness, it can be a nice option. And it's also, people say it's so cosmetically pleasing to everyone. So yeah, it's a good choice.
Right. So next question. How do you get an AFO covered under insurance? If it's not possible, are there any financial assistance possibilities out there for these?
Well, good question, Kendall. AFOs are generally covered by insurance every day. And it's something I've been doing for 35 plus years now. So it depends on the AFO. Some AFOs are just, how should I say, boutique type AFOs out there, and they're not covered for that. But certainly simple AFOs like custom AFOs people make out of thermoplastics and all the prefabricated or even custom carbon AFOs that are made, they're all covered by insurance, generally quite well. As far as financial assistance out there for other possibilities, I'm sorry, I don't know much about that. Yeah.
Let's go to the next one. Do hinged AFOs still help with forward propulsion?
Thank you, Mark. And the answer is no, they don't. Typically, hinged AFOs don't do well with getting that forward propulsion. If the brace isn't strong enough so that we call it a wall fall. So Mark, if you were to stand arm's distance away from a wall and then fall into the wall, if your heels don't come off the ground, then the brace isn't strong enough, and that hinge design you're in is not going to help you with that forward propulsion, and you're not going to gain back that 70% of propulsion that's lost by that problem, by not being able to get up on your toes.
Okay. My daughter is a ballet dancer. Can she wear AFOs for stability?
Ballet dancer. Boy, that's a really good question. It depends on your expectation for a ballet dancer. If she needs to be all the way up on her toes and all the way down in these positions, there aren't AFOs that accommodate that amount of, how should I say, motion up and down. We can get right up on your tiptoes and all the way down. I'm curious as to what her weaknesses would be, what her exact needs are at this point, how old she is and all that. A lot of questions with the question again. But you can wear certain things that'll just stabilize your ankle. If she's a ballet dancer and she's getting up on her toes, but the ankle is unstable, there are all kinds of AFOs that can be designed for that. Even free motion up and down that would still stabilize the ankle so that when she goes up and down, the ankle won't roll out. So yeah, there are some things that can be done for her, but again, it depends on her specific. There are so many differences from CMT patient to CMT patient, and so without doing an evaluation on her, seeing exactly what she needs, hard to say. But I'm sure there's something that can be done to stabilize her ankles while she's doing her ballet.
Fantastic. Okay. Any bracing considerations for arthritis on top of CMT?
Great question. And absolutely. Again, these dynamic carbon ground reaction AFOs, actually, they work great for patients with post-traumatic osteoarthritis of the ankle because they basically take the strain. They can take up to 70% of the work out of the foot and ankle. So imagine if every time you move that ankle, and generally with osteoarthritis of the ankle, especially if it's post-traumatic, if dorsiflexion is the enemy, if every time you're walking and your knee is now moving forward over your foot, if that's what hurts, if that's where your pain is, a ground reaction AFO can be really a big benefit there. Because imagine 70% of the work coming off of those joints that are being affected. If you can remove 70% of the work out of the joint, and that's in all three planes of motion as you're moving to, these are all triplanar joints. Oh my gosh, yeah. You can often walk pain-free, and a lot of times all that, associated pain and inflammation go away and improve.
Alrighty. What are the best AFOs for walking in the mountains or climbing with a foot drop and loss of ankle stability?
Great question. Thank you, Anna. And again, if that's what you really want to do is climb mountains, I'm talking boulders up and down. I showed an image of it earlier. The name of the brace is called the X-Turn. And if you write that down, EXTERN, your orthotist, or you can even Google it, you'll see this was designed by a guy in Canada who had foot drop and just didn't like anything else that was around. He had plastic braces and some carbon braces, and nothing gave him the motion that he was looking for. He needed to really have the foot pick up a lot to help clear a lot of uneven terrain. So he designed this thing. It's very impressive. The X-Turn also, because it's an external brace, it goes on the outside of the shoe. You can switch it from a dress shoe to a hiking boot, to a snow boot, to anything. Because it's big and it's a little bulkier, but it attaches to the outside of the shoe. But man, oh man, talk about good for mountain climbing. That's my go-to right there. Yeah, the X-Turn.
Awesome. Alrighty. So I live in Orange County, California. Where would I find getting AFOs that specialize in CMT? Is there a site to look this up? Or just in general, what is the best way to find AFOs and find a doctor to help?
Well, Orange County, I believe, because I went to UCLA, that's close to Los Angeles, Orange County. And of course, our own Dr. Pfeffer works at the CMTA Center of Excellence right in Los Angeles, and that's a great place to start. If you go to the CMTA website and just look up Centers of Excellence, that's where you would find the an orthotist that would specialize in Charcot-Marie-Tooth disease.
Righty. Let's see here. Can you use AFOs if you have high, I'm guessing, calves and hammer toes?
If you have high calves and hammer toes, I think high arches maybe in hammer toes. And the answer is yes. These AFOs are designed to accommodate all kinds of deformities and to help manage them, actually. So yeah, if you have high valves or ankles or calves or arches, yeah, we can pretty much accommodate all that with AFOs. Hammer toes are tough. Hammer toes is a broad term. There are 3 types of hammer toes. The most common one we've seen in Charcot-Marie-Tooth is a claw. So if you have it, this is your toe. It has 3 joints. Basically, if you have hyperextension of the MP joint and then you have flexion at the IP and flexion of the DIP, that's called a claw toe. And this is typically what happens when the toe sits on the top of the foot. There's not a lot you can do with AFOs for that. We really can't straighten out the toes, and that's sort of a surgical thing at this point. There's also this, so this is the claw, and then there's the hammer, which is actually, you get hyperextension, flexion, and then extension of the joint. It sort of sits like, you can see that sits like this on the floor. And then there's a mallet that goes straight out and just sort of flexes at the last joint. Like I said, the most common is a claw, second would be the hammer. Typically, those require surgery to get fixed. If it's having a real problem with them, like it can't fit in any shoes or anything like that, it's a good idea to have a surgeon straighten them out. But as far as higher arches and different shapes in calves and lots of atrophy, yeah, we can accommodate all those things with AFOs, absolutely.
Fantastic. So we will do one more question because we are nearing the end of this session. So let me go ahead and put them. Is a front AFO better than a back AFO for foot drop?
Oh, I'm so glad you asked that, Stephen. That's why I had that slide on it. Yeah, so for CMT patients, if you have trouble with balance and you can't get up on your toes, then absolutely an AFO in the front of your leg is better than one in the back. But again, it all really comes down to how well the forces are distributed on the front of your leg when you're leaning into it. So if the brace is in the front of your leg, it's usually got a nice broad area and it can be adjusted all kinds of ways to distribute those forces really well. Most CMT patients have a lot of atrophy, and they'll have what one doctor called saber shin, where that bone in the front of your leg can almost become sharp like a saber or like a knife. And we have to make all kinds of padding and adjustments to accommodate for that. But having that brace in the front of your leg makes the brace much more effective to manage both balance problems and to give you that heel rest for propulsion into your next step. So for most patients, unless you're just mildly affected, it's better to have it in the front of your leg. If you're mildly affected, then in the back is fine.
Fantastic. So that concludes the end of our session with Ken. I want to thank Ken for doing such an amazing job and providing so much helpful information. So now we can move on. It looks like we are at the lunch hour, so feel free to grab your lunch and meet us in the social lounge. We'll have all of our tables open, our community tables, our vendor tables, so please join us there. And that should start in just a few moments. Thank you, everyone.
Thanks, Sarah.